Hi there, ISM. I'm going to talk about some of the work we've done in the children's program, particularly UCL, Imperial and Lilac, about harnessing data to improve child health inequalities. So we're interested in how we can design better systems to improve child health and reduce inequalities. We have poor child health outcomes, relatively speaking, in the UK. It's difficult to put a positive spin on the numbers. We lag behind other wealthy countries when it comes to international rankings. You could choose many metrics to illustrate this. This plot shows under 5 mortality against relative child poverty. We have the highest under 5 mortality in Western Europe. And one of the reasons we do relatively badly on average is because poor children fare badly in the UK, and there are inequalities. This plot shows social gradients in children's outcomes at age 7 in millennium. We were interested in explaining some of these social gradients. So we're going to look at asthma in a second. So this is about understanding pathways and mechanisms that generate inequalities. And broadly speaking, we're interested in how we break this intergenerational cycle of social disadvantage, where adult social and health disadvantage in one generation affects children's early years outcomes, development, etc., affecting the health of the next generation. So we looked at asthma, which affects over 1 million children in the UK. It's the commonest chronic disease in children, and we're towards the bottom of the league for asthma deaths in young people. In this analysis, we wanted to know how and when inequalities in asthma were generated. And what we were interested in is using Millennium Cohort Study, how social factors affect the patterning of risk factors for asthma and how that goes on to influence risk of developing long-term asthma. This is a DAG, a causal diagram. First of all, let's look at the relationship between social disadvantage and risk factors for asthma measured in the first 3 years of life. I'll show you a number of these plots. They show a similar thing. This shows prevalence of smoking in pregnancy against a measure of disadvantage. You see a stark social gradient. The same for exposure to environmental tobacco smoke, for not being breastfed as a baby, for damp housing. And in this School for Public Health research analysis, we show that disadvantaged kids are almost twice as likely to develop the type of chronic asthma in adolescence that we know transmits into adulthood. And we show that about 2/3 of that excess risk is actually explained by perinatal and environmental factors experienced in the first few years of life, focusing efforts to address inequalities in asthma on the early years. A lot of the work we've done has been about looking at trends and variations and understanding patterns over time, particularly inequalities. We've looked at hospital admissions and A&E attendances. A&E attendances in kids have been going up year on year, and there's large geographical variation in children's emergency hospital use. A 60-fold variation in A&E attendance. You can see this further illustrated by geographical region for children under the age of, for infants, for A&E attendances and hospital admissions. And to explain these patterns of hospital usage, colleagues at UCL have undertaken a large data linkage project, linking mother and baby data within hospital episode statistics. And we can use that to look at the impact of maternal factors on risk of children's A&E attendance or hospital admission. So this plot shows the relationship between gestational age at birth and risk of A&E attendance or hospital admission and deprivation. And I guess in this analysis, we show that maternal factors are important, but there's huge unexplained variation at a local level in A&E attendance and also emergency hospital admission that needs further research. Extending this work, there's been linkage of ONS birth registration data to hospital episode statistics data for almost 4 million children to create a longitudinal cohort. And that data, those data have been used to look at the relationship between the intersection between maternal migration, so maternal region of birth, whether that's within the UK or in countries outside of the UK, and the intersection with social disadvantage. So what this plot shows is the rate of emergency hospital admissions by a measure of deprivation by maternal origin. And what you see actually is that the steepest social gradient is for children of UK-born mothers. And it's less pronounced in children whose mothers were born outside of the UK. And we've used this type of analysis to look at emergency hospital admissions, also planned hospital admissions, where you see a slightly different pattern, but a clear relationship with levels of deprivation. And this linked data set is being used at the moment to look at a range of different types of hospital admission. This shows planned admissions for dental caries, children having their teeth extracted. You can see the steep social gradient. And we can look at the intersection of maternal migration and childhood deprivation. We've looked at trends in infant mortality. This plot shows infant mortality by deprivation over time, showing an increase in infant mortality in the most disadvantaged areas. In our analyses, we've shown the relationship of this trend and rising child poverty. The trend is clearly related to increased levels of child poverty, but colleagues have also shown that it's related to the coding and of especially of preterm babies, and that the rise in infant mortality has occurred particularly in babies born between 23 and 24, so very extremely preterm babies. What's going on with children in the care system? We've tried to explain this precipitous rise in children taken into care in England. The next plot shows rates of children going into care by deprivation quintile. You're more likely to go into care in the most disadvantaged areas, and inequalities have been increasing over time. And in a series of analyses undertaken across the school, we've tested the hypothesis that austerity measures leading to rising child poverty and cuts to local authority budgets have influenced these trends. And indeed, both those pathways are in play. We showed particularly that rising child poverty has been a major driver of children ending up in the care system, contributing to 10,000 extra children ending up in care. We've looked at patterns of investment for children and collated this data in the place-based longitudinal data resource, showing that spending on children in the decade prior to the pandemic was a large increase in spending on looked after children at the same time as cuts to prevention for early years services. And we actually show that cuts to early years services have contributed, especially young people's services, have contributed to children ending up in care. And this evidence is featured recently in the Independent Care Review, which came out just last week. We've looked further at the impact of cuts to things like Sure Start. This shows cut per head over time, showing cuts to early years prevention, particularly in disadvantaged areas. What's been the impact of that? Well, we show that it's affected inequalities in obesity in children age 5 and later. This plot shows obesity prevalence by year, by deprivation quintile in local authorities in England, showing that pre-2010 obesity was coming down a little bit in the most disadvantaged areas, but there's been a reversal of that trend. And in this analysis, we show that cuts to Sure Start have had a causal effect on levels of obesity. And because the cuts were bigger in disadvantaged areas, these cuts have contributed to inequalities in childhood obesity. And this adds to other evidence that's shown the positive impact of early investment in reducing hospital admissions, improving child development, maybe influencing children ending up in the care system, and obesity. Other work across the school has assessed the uptake of the daily mile intervention, an intervention in schools where children run a mile, and it's been taken up to a greater extent in more disadvantaged areas, so proportionate to need. And that's led to work that's ongoing at the moment to look at the impact of the daily mile on on other health outcomes, mental health and educational attainment as part of the IMPROVE study. Pulling this together, what we're going to do about some of these challenges, well, I'd argue that the real meaning of levelling up is around earlier investment and at scale investment in children. If you want a pithy summary of what we need to do, we need to act early, act on time, act together. We need to reduce poverty and invest more in the early years for children. And the programme of research that we've undertaken has influenced a range of national and international and local policies. Clearly, there's a lot to be done to improve child health and implement the findings across numerous reports and inequalities reports that we've been involved with across the collaboration. But I would argue that investing in children, that's the real meaning of levelling up across this country. Thank you for listening.